Hi everyone, and welcome to this lecture on the adrenal drugs. This is Professor White. Let's get started. I changed this slide out from the one that you have uploaded online, and I felt it was a little more clear than the one that was available to you. So as I was going through, I thought I would put this up here for you to take a look at what are the adrenal glands. And the first picture on the title slide, we saw that they were these little glands that sit on top of the kidneys. So each kidney has an adrenal gland, so we have the right and left. And these glands have the adrenal glands have different areas of them, including the cortex and the medulla, and they secrete different hormones just based on what section we're looking at. So aldosterone, cortisol, and the androgens are all secreted by the cortex. And our catecholamines, epinephrine and norepinephrine, those are involved in fight or flight, are secreted by the medulla. So there's a negative feedback loop that works with this, just as we had learned previously what a negative feedback loop is. But the mnemonic that I've always learned about the adrenal gland with the cortex is salt, sugar, and sex. That just tells you for the cortex that's what is secreted. So aldosterone works with the salt values in our body, right? So it has a very intricate relationship with the kidneys as far as telling them to withhold water or to let water out. So aldosterone, cortisol, so sugar. So these are our items like our mineralocorticoids and glucocorticoids that are involved in metabolism of our carbohydrates and that use of sugar in our body. And then sex, the androgens. So those would be your testosterone and such that are also secreted. So that's just a little bit of housekeeping so that you understand what we're actually talking about. We often talk about undersecretion or oversecretion of hormones, and that's what gives us the disease states that we're interested in. So if we have too many of the hormones being secreted, specifically our mineralocorticoids, glucocorticoids, that leads us to something called Cushing's syndrome. So the words used to describe that are moon face, humpback, hirsutism, right, which is the extra hair growth, ecchymosis, so they're easily bruised, they have increased blood pressure, and their potassium can drop, sodium goes up. They have generally insulin resistance, so their glucose tolerance is very friable, and their muscles can atrophy. And on the abdomen, there's something called purple striae that we look. And those are signs of Cushing's syndrome, which coincidentally goes along with long-term steroid use as well, because we're giving them these glucocorticoids, mineralocorticoids. Now, if we don't have enough of these steroids, that can actually lead to cardiovascular collapse and death. So what we see is the body unable to maintain sodium and glucose, which we know glucose is imperative for human functioning, for any organism really. The potassium increases as the person is dehydrated and they develop weight loss. So again, an Addisonian crisis is life-threatening. When we have an oversecretion coming from the adrenal glands themselves, the most common treatment that we do is an adrenalectomy. So we'll actually remove the adrenal glands. It's usually as a result of some sort of a tumor or something. So that's the treatment. When we have undersecretion, what we need to do is basically give them the replacement of what their adrenal glands are not making, right? So these are synthetic or natural. We have all different types. The glucocorticoids, and we have mineralocorticoids. And there are some steroid inhibitors, but again, they're not used as often as you might think. Our glucocorticoids are used very frequently in nursing care. There's a ton of different meds that are available, whether they be inhaled, like for allergic rhinitis, they might be applied topically to rashes. There's all different types. We inhale them for COPD and things. Our mineral corticoids, those are always systemic, and right when they're given, they're actually much stronger, the mineral corticoids as a class. So here are some of the glucocorticoids that you may be familiar with: hydrocortisone, cortisone, methylprednisolone, triamcinolone. See, what do they all have in common? Look at all of the different meds we have available. They all end in -one. So sones and lones, basically. So cortisone, dexamethasone. So that's going to help us remember these by class. Now, the other adrenal drugs that we concern ourselves with, here you have the mineral corticoids: aldosterone, fludrocortisone would be the most common, epinephrine and norepinephrine. When we give those drugs, that's usually for shock states and anaphylaxis. And then cortisol synthesis inhibitor. This is a medication that's not seen very often, but oscillodorostat, just something to be aware of, nothing that you would probably have option or opportunity to give in your career. All right, so this slide just talks about the mechanism of actions of basically we're talking about glucocorticoids, mineral corticoids, specifically glucocorticoids. One thing to remember is that glucocorticoids and these steroids in general, they inhibit the immune response and the inflammatory response. So if we know that, then we know that our patient is at higher risk of infection. This is why these are not generally given in infection. In very rare cases, you'll see them, and that's basically a Hail Mary to try and save a patient's life when we have an overreaction of the immune system to like sepsis or something. But that same inhibitory response is really great for certain autoimmune conditions and otherwise. So lots of different reasons that we would see that patients are taking these medications. Just had to fix that real quick. So you can read them on here, but in general, we're giving them for lots of autoimmune disorders like lupus, things like ulcerative colitis, COPD, people who have bleeding tendencies, endocrine disorders like thyroiditis. When we talked about thyroid, we might give these medications to help with that. Some of the other reasons we might give it are on this next slide for you, right? If the person has an organ transplant, we do not want the immune system to reject that. So we sort of modulate the immune system so it's not so active. Leukemias and lymphomas, nephrotic syndromes, spinal cord injuries, right, to decrease inflammation surrounding that injury. We had mentioned previously that glucocorticoids are given different routes, so you have to look at which route the patient is getting it. So inhalation for a lot of COPD and asthma. Nasally for rhinitis, think about fluticasone, which is Flonase, that people take very commonly. We give steroid drops into the eyes, the ears, the skin. So let's look at some of the things we need to worry about before giving them. Specifically, let's look at our contraindications, right? So an allergy to a medication is an allergy that, is a contraindication to whatever medication you'd want to give. So if you have an allergy. If you have a severe infection, because remember, what these are going to do is turn down the immune response. So the patient with an infection, we need to give that information to the provider prior to administering these medications. That being said, certain illnesses, we can actually decrease the inflammatory response that is very protective. So you can see there's, that's nursing in general, right? There's always little nuances to things. We have to be very careful in patients who have gastritis, if they have reflux, if they have peptic ulcer disease, because this can actually lead to the development of ulcerations. So that's something we're always looking at our patients for. Diabetes, right? Because diabetes is got to do with our sugar regulation, and these medications cause increases in blood sugars. And then, of course, as we always state, any cardiac, renal, or liver dysfunction, let's make sure the doctors are aware of that before prescribing. When we give these drugs, they affect every single body system. All right, cardiovascular, you can see, right? Heart failure, edema, especially medications that we give, like fludrocortisone and stuff, right? They are specifically implicated in heart failure, but long-term use of any of these medications can cause cardiac effects. You can see the central nervous system. Certainly you can read this. People who are on long-term glucocorticoids can have growth suppression. This is very, very important if we're dealing with children, right? Because we may disrupt their normal growth pattern. They may end up having a lot of other issues. Remember that when we start to give something to a patient, that their body will naturally not make it anymore, because the body wants to maintain homeostasis and water balance. GI, you have peptic ulcer disease can result as this, esophagitis, abdominal distension. Let's keep going. The skin can become fragile, petechiae, striae, facial flushing or erythema, can develop poor wound healing, right? This isn't a concern of ours as we're dealing with patients with any sort of surgical wound or pressure ulcer or anything like that. Muscle weakness, loss of mass, osteoporosis, which can lead to fractures. The eyes are also affected, can cause glaucoma and cataracts, and then weight gain. So there are a lot of adverse effects, which is why the rule is that we want our patients on these medications for the lowest dose for the lowest possible time. We want to go ahead and make sure we're not unnecessarily giving them side effects and adverse effects if we can avoid it. Some of the interactions. These are some of the big ones. So any of our biologic agents can also they can interact and have decreased response of our biologics. It's kind of something you can think about a little bit later. It's a kind of an advanced topic for right at the moment. Blood sugar elevations can occur if we're using anti-diabetic drugs. A lot of our non-potassium sparing diuretics, so these would be potassium wasters, they can end up with severe hypokalemia and low calcium. Anybody on aspirin, NSAIDs, they are at increased risk of ulcer formation. So again, something we need to be aware of. And myasthenia gravis, those patients take anticholinesterase drugs to help with their disorder, and if we give them steroids, it will cause increased weakness. All right, let's take a look what else we have here. Our corticosteroids are considered pregnancy category C drugs, and a big thing that we need to look at is that any steroid that we're giving must not be stopped abruptly. This is the reason we taper these drugs down. We don't stop them because, remember, the body will not make what we are giving it. So our patient who has been getting a glucocorticoid, their system will not make it. So if we withdraw that abruptly, the patient can basically go into an Addisonian crisis, an adrenal crisis, and suffer cardiovascular collapse. And we're going to spend a little bit of time to talk about some of the other meds that we have here. So fludrocortisone or Florinef, you can see I'm just running this, so sometimes I say that there's like a grammar error or something. It's because it's not in presentation mode. But fludrocortisone is a mineral corticoid. It's basically one of the ones that does need to be replaced in Addison's disease, so Addison's disease, because what it does is it helps with the salt balance, right? It helps us to maintain sodium in the body. So the rule is that water does follow salt, and when we have sodium retention, water retention will be right behind it, right? So what can happen if we have too much water on board, right? The patient can suffer heart failure, high blood pressure or hypertension, and it can increase their intracerebral pressure. So that are the big side effects of this med and what we have to watch out for. So as a result of that, we do have some patient teaching that has to go along with this, right? So what do you think you would want to teach a patient who is on fludrocortisone? What did your book tell you? Well, things we know already. Don't ever abruptly stop this, right? Because the body does need this to survive. Taking it with food can help with the GI upset, but the big takeaway here is to make sure that our patient is not gaining too much weight, because that can predispose heart failure, right? That can be a symptom of it. So they need to take their weight and they need to report a 5-pound weight gain in a week. That's very important, okay? We don't want our patients in heart failure. And I'm sure we'll say this going forward, but these medications are generally taken in the morning. I don't know if any of you have ever been prescribed any medications that are steroid class of meds, but if you take them later in the day, I mean, you get a rush of energy. The patient may be up all night, and so that's why we take them in the morning if possible. Okay, so prednisone, this is a very, very common med. It is the most commonly used oral glucocorticoid, right? So you are going to give this medication. You are responsible to know all about it as a result of that, right? It is one of the most commonly prescribed meds. We use it to treat exacerbations of chronic conditions, specifically COPD. If somebody has like a rash, I mean, there's all different reasons a person could be on it. But understand that prednisone is not strong enough to treat Addison's disease. They need the stronger stuff. So prednisone, very common. All of the rules apply. We don't abruptly stop it. It needs a taper. And give it in the morning. Give it with food. Solumedrol or methylprednisolone. This is an injectable glucocorticoid, usually given IV. And it is also available in a long-acting formulation, so you can see that it's not available to anybody under 28 days because of that. So just understand that methylprednisolone is the basically IV form of the steroid that we would give. This is going to be very commonly given in our hospitalized patients. Okay, so let's go into some of the nursing implications. Anybody that is going to be on any sort of adrenal replacement drug, we're going to want to look at their baseline height, weight, intake and output, their vital signs. Blood pressure is the most important of that. Looking at their immune status, any infections, anything that we need to be aware of. Looking at their baseline labs, right? Baseline labs tell us how are our kidneys functioning, how is our electrolyte balance already. And looking at edema, we assess the skin. Because remember, these medications can cause changes in all of that. And then again, assessing for those contraindications, especially peptic ulcer disease. Honestly, with these meds, a lot of times the patient starts to get GI upset, and that necessitates a proton pump inhibitor to be added, because that way we can basically avoid peptic ulcer disease. Do a good thorough history. Make sure you know what the patient is taking, not just prescription, but over the counter and herbals. Remember, we said these drugs can alter blood sugar levels. This is especially important in diabetics, but even non-diabetics can have these alterations. We do not give subcutaneous injections of this. And you're expected to be able to prepare and administer these per the manufacturer instructions. So, for example, Solumedrol is it's actually one of my favorite drugs to put together, because it has a glass vial that has a rubber stopper in it, and I'm able to push the rubber stopper down and it drops some fluid into this powder, and it's actually just a joy. for me to make up. So I digress, but you have to know how to prepare them. So the manufacturer will give you instructions. Some other things, remember, oral forms, let's give them with food or milk. Sometimes if we're giving topical, it requires a dressing. Other times it's rubbed into the skin. Remember to always wear gloves. Anything that can be absorbed by the patient can be absorbed by you. So you are responsible for these sort of precautions for your own safety. Anytime we're going to give a nasal spray, we want to have the patient clear their nose, and that way we get the best, coverage, I guess, so that there's not any mucus or anything, that this can actually touch the mucous membranes. After we give anything orally inhaled steroid, they're at high risk of fungal infections from that, so you always want to rinse your patient's mouth out, have them rinse it out. There's no excuse for us not to. What else? Steroids decrease our immune responses and can leave people vulnerable to infection. So we need to practice good infection control and make sure they understand to report any signs of infection to the provider. And again, all meds at the same time every day in the morning with meals. Don't take these medications with NSAIDs, alcohol. Again, that's going to be for the increased chance of gastric ulcers. And then what else do we have? One more slide here. Remember not to stop these drugs. I think I've said it probably 6 times in here. Taper them before they're discontinued. Monitor for therapeutic responses, and then adverse effects as well. Now, the one thing I will note is that often, as I'm just circling through here, often we have to give patients multiple inhalers. And if you're going to give something like a steroid and you have a bronchodilator, I want to make sure you know to give that bronchodilator first, right? Bronchodilator is open, and then when we give that steroid, it can go deeper in. So we always would want to give those first. But other than that, hopefully this wasn't too long and you've learned a little bit. And thank you very much.